Sudden onset dyspnea and pain. Along with chest pain, you will have shortness of breath as well. It will be of pleuritic type with pulmonary infarction. Pleuritic chest pain means the pain which increases on coughing, which increases on deep inspiration, and gets relieved on holding the breath. And pulmonary pressure patients will have associated dyspnea, tachypnea, tachycardia, and signs of right heart failure. Then pericarditis is other cause of cardiovascular cause of chest pain. Pericarditis chest pain will be same like pleuritic chest pain, but that pain usually changes in position, and it is variable in duration, and the patient will have a pericardial infection. Then pulmonary cause of chest pain will be usually pleuritis or pneumonia. They will have pleuritic pain over the inward area and lateral to the midline associated with dyspnea. Then spontaneous pneumothorax. Spontaneous pneumothorax patients will have associated underlying sudden onset unilateral pleuritic pain with dyspnea. Dyspnea will be more than chest pain, so it will not be misleading. Then other causes are like gastroesophageal reflux, burning, substernal or epigastric discomfort aggravated by large meal or postprandial recumbency relieved with antacids. That is typical gastroesophageal reflux type of pain. Other causes. Costochondritis can also present with chest pain. That pain will be usually sudden onset and intense fleeting pain. It will be reproduced by pressure over the affected joint. Costochondritis means inflammation of the cartilage and bone of the ribs. That type of pain will usually have associated tenderness. But pain and it will be localized. Patient will typically tell, here is my pain. Coronary pain will not be usually localized. So, 99% it is not related to heart, because coronary pain will not be usually localized. Then cervical disease type of chest pain, it can be reproduced with movement of the neck. Then trauma or strain. These type of patients will have history of trauma, and the pain will be constant, reproduced by compression or movement of the chest or arms. And few other causes, like infectious causes. One of my friends, my school friend, none of the friend of him, he called me saying, my father has severe chest pain. I told, I was in Bangalore, I told, visit nearest cardiologist. Then cardiologist saw ECG, everything was normal. Then he was telling, sir, I have severe pain, sir. Okay, open the chest. They opened the chest, then they realized there are rashes. It was herpes. It was prolonged burning pain in dermatable distribution. Vesicular rash, dermatable distribution will be there. So it is part of examination to expose the part of chest pain. Then other causes of chest pain are like psychological, panic disorder, chest tightness or aching, often accompanied by dyspnea and lasting 30 minutes or more. And it is usually not related to exertion or movement. It will be usually associated with other evidence of emotional disorder. So now we will discuss about some basic definitions of acute coronary syndromes. STEMI, you might have heard STEMI anytime. STEMI means ST elevation MI. Definition of ST elevation MI is at least 1 mm or more ST elevation in 2 frontal streets of ECG. Non-ST elevation MI is where there is myocardial infarction with no ST elevation in ECG. But how will you get to know it is MI? It is by troponin. The ECG and echo will be normal, and troponin will be positive. Troponin is cardiac biomarker which will be positive in blood test. It is enzyme released by death of the myocardium. That will be found in blood. When we do blood test, we will get to know that troponin is present in the blood, which is released from dead myocardium. So heart attack might have happened. So third definition is unstable angina. Unstable angina is that acute angina, but with normal ECG and even troponin is also negative. So these two things which we all should know. What is angiogram? What is angioplasty? So angiogram means, what is electrocardiogram? What is it? It is a type of investigation. So in the same way, angiogram is like electrocardiogram. It is a type of investigation to detect blockages in blood vessels of heart. So angioplasty is a procedure to detect, to treat those blockages, to clear those blockages. So this is just a video to show what is angiogram. We give dye injection by hooking exactly to the coronary artery, you will have arteries or pipes with the typical bends in it and its end to direct it to coronary artery. So we inject into coronary artery and we'll take X-ray notice. Same like X-ray, it is video of the X-ray. That contrast dial will be seen on this video. We can see there is a total cutoff in that coronary artery. Left entry descending artery it is. There is total cutoff in the middle already. So this is coronary angiogram to see blockages in blood vessel of the coronary artery. So this is the next step. You can see the wire. Over that wire, 2 dots. That is the balloon. That balloon is passed over that wire. This is balloon. We expanded that balloon over that lesion area. This is placement of stent. After placing stent, this is the blood flow we achieve. So to explain it, first one wire active. A wire ಮೇಲ್ಗಡೆ ಸರಕ್ಕೆ ಮಣೆ ಕೊಡಿಸಿದಂಗೆ balloon active. That balloon will be of around 2 or 2.5 millimeter diameter, length of around 15 mm or 18 mm. A balloon expand ಮಾಡಿ ಅಲ್ಲಿರೋ ಬ್ಲಾಕೇಜ್ ನ ಓಪನ್ ಮಾಡಿ ಅದಾದ ನಂತರ ಇದು ಸ್ಟಂಟ್ ಹಾಕ್ತಾರೆ. ಆ ಸ್ಟಂಟ್ ನ ಪ್ಲೇಸ್ ಮಾಡ್ತಾರೆ. ಸ್ಟಂಟ್ ಹೆಂಗೆ ಇರುತ್ತೆ ಅಂದ್ರೆ ಸ್ಟಂಟ್ ರೆಫಿಲ್ ಒಳಗಡೆ ಸ್ಪ್ರಿಂಗ್ ಇರುತ್ತಲ್ಲ, ಆ ಸ್ಪ್ರಿಂಗ್ ತರ ಇರುತ್ತೆ, ಬಟ್ ಸ್ಪ್ರಿಂಗ್ಸ್ will be little thicker. Struts will be little thinner. It is of 50 to 80 micron. So it will get expanded. After that, we'll expand that stent with another balloon and achieve the flow. This procedure is called angioplasty, where blockage is cleared. So we'll discuss some case scenarios. You may think little higher level for your first year or second year, but just listen. Whatever you understand is advantage. So we had a 54-year-old male who came with history of inability to walk. And the restriction of walking is typically because of chest heaviness. And he comes with relief of pain as well as he rests. So what is it? Yes, it is angina. And the recurrence of pain soon after restarting to walk. This is typical angina. This happens more or early during climbing steps. This is complaint. So this is typical angina. So what next? No. First we have to confirm diagnosis with basic ECG and echo. Before doing angiogram, we have to know his basic profile. If his LV dysfunction is severe enough, we have to take more caution during angiogram. Yes, angiogram is the first step, but before that, we have to know little basics about the patient. For that, we have to do ECG and then angiogram. So, another history: 24-year-old female coming with chest pain on exertion, relief or rest, recurrence of pain on walking. So what is it? Angina. But it is 24-year-old female. Do we expect 24-year-old female to have blockages in blood vessels of the heart? Very less likely. Very less likely.
Anemia also.
Yeah. We have to rule out anemia. So, but ECG echo as a basic evaluation. Anemia is the most common cause of angina type of chest pain in young females. You might be knowing one sentence that females are protected of coronary artery disease because of estrogen. Coronary artery disease are diseases of males. Females will get coronary artery disease or heart attacks only if they have associated underlying comorbidities like diabetes, hypertension, thyroid, or dyslipidemia. Even without all this, if they have coronary artery disease, it means they have underlying family history or they have underlying history of hysterectomy done along with ovaries. We have to preserve ovaries during hysterectomy. If ovaries are not preserved, she will lose the lifelong estrogen support. So, she will be at risk of developing coronary artery disease. So, case scenario 3 is 25-year-old female, chest pain occasionally, localized, usually while sitting or lying down or during rest, not aggravated by exertion. What is it? It is not angina type. So it is not cardiac pain. Pain while sitting or lying down or at rest, not on walking or exertion. If it is During exertion, it should be of coronary. If it is not related to exertion, it is less likely coronary, and to that will 25-year-old female, it is very less likely. So what next?
Any traumatic?
We still have to do one basic ECG because you never know who can have underlying what manifestation. Then another case scenario: 56-year-old male with sudden onset chest heaviness associated with sweating, lasting more than 20 minutes. It was intolerable pain, and the pain is still ongoing. And he typically describes the pain aggravates on walking, even for 2-3 steps. But ECG is normal. So next step is proton. It is negative. Echo is normal. No, TMT is contraindicated when you have typical hypertension. If a patient is telling chest pain on exertion, what more do you want to prove it is coronary? So angiogram is the next step. It is considered as unstable angina. So any patient with hypertension, ನಡೆದ್ರೆ ನೋವು ಬರುತ್ತೆ ಅಂತ ನೋಡಿ TMT ನೋಡ್ಸಿದ್ರೆ patient can collapse on TMT because hypertension itself indicates underlying significant coronary blockages. If you make a patient with significant coronary blockages to run on TMT, he may collapse because on exertion there will be increased oxygen requirement of myocardial. Coronaries will not be adequate enough to increase the blood flow to myocardial. He will develop angina again. That ischemia can develop VT and sudden cardiac death also. So next, what next will be? Repeat ECG or troponin or read like ACS. So this is ischemia cascade. This is the new thing to everyone here. Ischemic cascade means you can see left side first green color is normal function. Second step is perfusion abnormality. So whenever a patient develops blockage in blood vessel of the heart, which is of significant like more than 90% or up to 100%, initially he will develop perfusion abnormality, then develop diastolic dysfunction initially, then systolic dysfunction, which are detected in echo only. Then will develop ECG changes, which are of ischemic. So echo changes are seen first, then ECG. After that, myocardial necrosis. It means troponin is positive after ECG changes, after myocardial necrosis is seen, which is usual. But that doesn't mean ECG should show something even before troponin is positive. So this is the usual protocol we follow. Whenever we suspect ACS and we do troponin, if troponin is high, we consider it as MI. If troponin is low, we usually repeat it, depending on underlying probability. If troponin is negative and the underlying pretest probability is very low, like no comorbidities, or patient is of young female, like that, it is we consider it as rule out. If patient is of 50 plus, diabetic hypertensive, troponin is negative, ECG is normal, but still chest pain is present, ongoing chest pain is present. In that case, we observe for 3 hours, repeat ECG, repeat troponin, do echo. So next case scenario is 58-year-old male, diabetic hypertension in 6 months, has chest pain episode, not sure if related to exertion or related to pressure. ECG, echo, troponin, everything normal. How to proceed? 56-year-old, diabetic hypertensive. Pain is not of angina. ECG, echo, troponin, everything is normal. Pain is not suggestive of angina type. How to proceed? We keep on addressing angio for each and every chest pain, patients will say it is revenue generating model. So we consider it as atypical chest pain, and the next step is either TMT or CT coronary angiogram, depending on patient's preference. If patient cannot walk because of his leg pain or knee pain, we can advise TMT. The TMT is advised when the pretest probability is intermediate or low. That is, when ECG, echo, troponin, everything is normal, chest pain is not of angina type, and underlying comorbidities are there, if we are suspecting anything. So 58-year-old male diabetic, since 15 years, presents with fatigue and dyspnea on exertion since last 2 to 3 months. ECG, echo are normal. How to proceed? Fatigue and dyspnea, no chest pain. So diabetics can present even without chest pain. So we consider fatigue or dyspnea or vomiting sensation in diabetics as an angina equivalent. And any patient, any diabetic patient elderly presenting with fatigue, vomiting or dyspnea, we have to do an ECG. ECG is must. it is a typical symptoms increasing on exertion since last 2 to 3 months. So better to consider it as an engine equivalent and start antiplatelets and consider for elective angiogram. This is especially when the patient is of long-standing history of diabetes. So these are some points like radiation to right arm of shoulder is also possible in coronary disease, radiation to arms. Then other angina equivalents are dyspnea, diaphoresis, that is fatigue and nausea. Next case scenario is a 62-year-old male, diabetic hypertensive, chest or epigastric discomfort, heaviness after having meals. Sometimes similar pain on exertion or during post-application. What can it be? So, any chest or epigastric discomfort or heaviness, especially after having meals. It can be GERD for a normal patient, but in a patient with diabetic hypertensive with associated history of similar pain on exertion, we should consider it as postprandial angina. So postprandial angina has a risk of underlying triple vessel disease most likely. So we cannot just neglect chest discomfort or heaviness in the chest after having meals as just GERD or gastrointestinal, especially in elderly diabetic hypertensive patients. We have seen patients like this who have underlying triple vessel disease mostly. So next step is start antiplatelets, anti-anginals, and consider for coronary angiogram. So significance is triple vessel disease. So 45-year-old man, sudden onset chest pain, radiating to back. The patient will have hypotension, BP will be very low, in shock. What is the possibility? Aortic dissection is the possibility. What next? What will ECG give? Yes, ECG will guide us basically whether aortic dissection has involved coronaries or not. Sometimes aortic dissection will have flap extending into right coronary to cause inferior volume. But that will just guide us association of inferior volume. But management depends on next step to image aorta to confirm the dissection by CT aortic. Then emergency surgery. Any ascending aortic dissection, the final and the treatment is surgeries. I had a friend of mine whose parent developed aortic dissection. He was taken to hospital some 3 hours from here. They admitted the patient, and because there was no surgeon available, the patient was kept in the hospital for next 6 hours till deterioration. But surgery was not done because surgeon was not available. So this should have not been done. So aortic dissection patient, if we have to make the patient alive, surgery is must, especially in ascending aortic dissection, unless there is underlying contraindication. 42-year-old male came with syncope, history of insidious onset chest pain and dyspnea for 4-5 days, with history of fall from bike followed by leg swelling, noticed since last 10 days. What is the possible diagnosis? Pulmonary embolism. So how will you proceed? For confirmation of pulmonary embolism, immediate echo to see RIA dilatation, right heart pressure increase. But when confirmation of the diagnosis is CT pulmonary angiogram to confirm blockage in pulmonary artery. How do we manage pulmonary embolism? Thrombolysis, injection streptokinase, tenecteplase or eteplase can be used. Then anticoagulation to be continued. So 38-year-old male, chest pain for a week, aggravates on coughing or weak breathing, history of fever for 1 week with history of tachypnea. What is the possibility? Fluoride or pericarditis. Next step is to evaluate underlying ECG. Then 52-year-old male presented with acute onset dyspnea with tachycardia, hypotension, with history of chest pain 1 week back, lasted for a day. Possibility of tamponade. So in tamponade, initially the patient will develop pain because of pericarditis. As soon as blood or fluid gets collected in pericardial fluid, he will lose that pain. The pain will be relieved because the fluid will prevent friction between pericardium, pleural and what we call parietal and visceral pericardium. So pain will be relieved. So what is the next step for tamponade? Tamponade is pericardial effusion. Massive pericardial effusion causing hypotension is tamponade. Next step in management will be pericardial stenosis after confirming the diagnosis by echo. So let us see ECGs little quickly. If ECG is too high for students, so we can see ST elevation in lead 2, lead 3, and lead heavier. This is ST elevation MI, inferior MI. Students can consider this as a motivation to read ECG. What is the need of ECG? So this ECG 2, you can see ST elevation. This is a tombstone type of pattern of ECG. We call it as ST elevation in V2, V3, V4, V5, V6, and the reciprocal ST depression in lead 3. This is extensive interval MI. Next, this is 43-year-old male, white chest discomfort, dyspnea, and tachypnea, and cuts. This ECG was of a patient when I was in Apollo. This patient was treated from casualty as a respiratory tract infection because patient had dyspnea, chest discomfort, and little breath. And then they gave a reference to CECG. We got to see this ECG. We can see subtle changes, ST elevation in avial, ST depression, reciprocal ST depression in lead 3, and the V3. ST depression in V3 indicates posterior wall MI. So this is lateral wall plus posterior wall MI. When we did angiogram, it was LCX totally excluded. Then 58-year-old male with acute chest pain having this ECG, ST elevation in AVR, ST depression in all other leads. So this is the LMC pattern of ECG. We should consider it as NSTEMI and treat as ACS. So these are the different changes in ECG which are significant. 56-year-old diabetic with no chest pain, dyspnea on exertion since last 1 to 2 months. Yeah, we can see T inversions in V2, V3, and V1. So the diagnosis is old interval MI. 40-year-old male with chest pain on walking with this ECG. Chest pain on walking will be considered angina, and with this ECG. T inversions, deep inversions in V4, V5, V6. HCM was diagnosis on echo. We cannot diagnose HCM on ECG and just history. Another ECG is 26-year-old manual labor with left shoulder pain coming with this ECG. Any comments? Yeah, this type of ST elevation is early repolarization pattern. This is not MI. This is typically seen in heavy exercise doing workers or athletes or young male tall built and manual laborers. This heavy working pattern like that. So 56-year-old male, back pain on exertion. This ECG is of one of the patient from Kudligi who had come to Jaya with this complaint. He was developing back pain on walking, no chest pain, only back pain on walking. There were subtle changes in ECG. T inversion in V2, which is not normal. It was anteroseptal wall MI. And he had proximal LAD, which was diffusely calcific stenosis of 90%. We opened it and checked it, and he is all right. 23-year-old female with chest pain with this ECG. You can see subtle changes, just like previous ECG, where T inversions in V2, V3. But because this is 23-year-old female, young female, this ECG changes can be normal. We call it as juvenile T-wave pattern. So next is you can see changes of ST depression in area and ST elevations all over. This is typical of pericarditis, where ST elevations will be there in all the leads, not localized to only LAD territory or RC territory. Next part of the session is management of coronary arteries, that is acute MI. So this interesting slide is what I see. How the evolution of management of coronary artery disease was seen. In 1950s, whenever anyone used to develop heart attack or coronary blockages in coronary vessel, they used to just observe. It was research based. They used to just observe by keeping the patients in ICU how the patients will proceed, how they will evolve, and what is the natural history of the coronary artery disease when they develop coronary artery disease. So in 1960s, they started using defibrillator. because many of the patients used to develop VT. VT is the most common cause of death, ventricular tachycardia. So ECG was invented in around 1904. So they used to diagnose VT during that observation phase in 1950. In 1960s, when defibrillator was invented, they started using defibrillator in that intensive care, and they saved many of the lives with just defibrillator by giving shock in that VT. So in 1958, streptokinase was discovered. After that, they started using streptokinase for ST elevation MI. Then in 1970s, for those myocardial infarction patients who streptokinase was used, they considered revascularization for the blockages that present by coronary artery bypass graft. Bypass surgery was invented in 1960. First time it was done in New York. Then in 1980s came new invention. In first time done in Switzerland in 1977. Balloon angioplasty was done by some anti-currents. Then so heart blockages is there. ಬರೀ ಬಲೂನ್ angioplasty ಮಾಡಿ ಬಿಡೋರು, ಅಂದ್ರೆ ಬಲೂನ್ ಇಂದ ಎಕ್ಸ್ಪ್ಯಾಂಡ್ ಮಾಡಿ ಬ್ಲಾಕೇಜ್ ಕ್ಲಿಯರ್ ಮಾಡಿ ಬಿಟ್ಬಿಡೋರು. ಆಮೇಲೆ ಒಂದು ಸ್ವಲ್ಪ ಜನ ಬಿಟ್ಟು ಮಾಡೋರು, ಮತ್ತೆ ರೇಸ್ಟಿನೋಸ್ ಆಗಿರೋದು, ಅಂದ್ರೆ ಎಲಾಸ್ಟಿಕ್ ನೇಚರ್ ಆಫ್ ಬ್ಲಡ್ ವೆಸಲ್ ಇಂದ ಇಟ್ ಯೂಸ್ ಟು ರಿಕಾಯಿಲ್. ಸೊ ದೆನ್ ದೇ ಫೌಂಡ್ ಅ ಸೊಲ್ಯೂಷನ್ ಟು ದಟ್ ರಿಕಾಯಿಲ್. ದೇ ಇನ್ವೆಂಟೆಡ್ ಬೇರ್ ಮೆಟಲ್ ಸ್ಟಂಟ್, metallic stunt like metallic cylindrical shaped structures to keep in that portion of blocked blood vessel and expand it to make that metal stay there such that there won't be recoil. Then they noticed there was instant restenosis. Within that stent, there was restenosis developing early after stent. So then they discovered after 2000s drug-eluting stents. So over that bare metal stent, over that metal part of stent, they eluted drug anti-metabolites. You know, paclitaxel, sirolimus, everolimus. That will be eluted over that stent and placed instead of placing a direct metal. That drug used to prevent restenosis by preventing growth of new cells in that area, so that early restenosis is prevented. So as of now, we are using drug-eluting stent. The stent we are using stent is looks like similar to the screen in above the pen, and it will have drug coated over it. The drug can be everolimus, sirolimus, or paclitaxel. It is there in the market since 2002. Last few slides. IST or coronary artery disease. It includes either acute coronary syndrome, which includes unstable angina, STEMI or STEMI, or stable ischemic heart disease, which require antiplatelets and statin and direct angiogram for the evaluation. So the last portion of our lecture is management of this acute and stable ischemic heart disease. So whenever we diagnose this unstable angina or STEMI or NSTEMI, we discussed about how to diagnose unstable angina, how to diagnose NSTEMI, and how to diagnose STEMI. Now we discuss about how to manage it. So first thing, whenever we see a patient with angina or unstable angina or NSTEMI or STEMI, first thing we have to do is to give loading dose. What is loading dose? Loading dose includes aspirin of 325 mg. We call it as Disprin tablet, Disprin 325 mg tablet. It is chewable. With chewing, it will have instant absorption. Next step is clopidogrel. It is not next step, it is all together given. Aspirin 325 mg chewable tablet, then clopidogrel 300 mg, 75 mg 4 tablets, then atorvastatin 80 mg. And as soon as we give these tablets, along with this, we have to give either 5000 international unit of heparin intravenously or low molecular weight heparin, that is Lexan 60 mg subcutaneously. These four are the basic preliminary things which we are supposed to give whenever we find a patient with ACS. Whenever we label a patient as effort angina, unstable angina, STEMI, first thing we have to give. So what is the next step after giving these things? Other medications like oxygen. Only saturation is less than 90. Oxygen cannot be administered just because the patient is MI. We diagnose the patient of MI, ambulance plus oxygen plus. There is no point in putting oxygen if saturation is less than 90. If saturation is not less than 90. So anti-anginals like nitrates. You might have seen a number of Instagram posts, reels, people telling sorbitol ಅಂತ ಒಂದು ಟ್ಯಾಬ್ಲೆಟ್ ಇರುತ್ತೆ, ನಾಲ್ಕು ಕಡೆಗೆ ಹೋಗ್ತಂತೆ MI ಆದ್ಮೇಲೆ ಸರಿ ಹೋಗುತ್ತಂತೆ. No, it is just an anti-anginal. It will just reduce pain. It is not going to do anything other than dilating coronary vessels to decrease pain. But we have to rule out hypotension before giving that sorbitol tablet. We cannot just say ಹೌದು MI ಬಂದ ತಕ್ಷಣ ತಗೊಳ್ಬೇಕಂತೆ, ಒಂದು ಟ್ಯಾಬ್ಲೆಟ್ ತಗೊಳ್ಬೇಕಂತೆ, 4 ಟ್ಯಾಬ್ಲೆಟ್ ತಗೊಳ್ಬೇಕಂತೆ. ನೋ, ಯು ಹ್ಯಾವ್ ಟು ಗಿವ್ only after ruling out hypotension. And benefit of sorbitol is that sorbitol tablet which contains nitrate, glyceryl trinitrate, is only pain relief, that too for instant. Then other medications to be given are like morphine. If patient is immunologically stable and patient is complaining of severe pain, we can use morphine as an anti. We can use it as analgesic. Then beta blockers will be started within 24 hours if not contraindicated. So this is little basic definition of STEMI and NSTEMI. Anyone who can comment what is the difference between STEMI and NSTEMI? ST elevation MI, non-ST elevation MI. What is the difference? Simple as that. ST elevation MI and the vessel is completely occluded. Here time is myocardial because the vessel is completely occluded by 100%. Each and every minute is important. If we allow the patient to progress over the next 1 year, 1 hour, patient will lose 60% of the myocardial supplied by that blood vessel. Maybe by over 6 to 7 hours, 100% of the myocardial supplied by that blood vessel may get died if collaterals are not available. That is ST elevation where the occlusion is 100%. Here the irreversible damage starts within 20 minutes of the occlusion. So management of ST elevation is emergency primary PCI. So any patient with ST elevation, we have to open the block the 100% blood vessel immediately. Non-ST elevation, it is blockage in blood vessel by more than 90%, but not 100%. Here early angiogram is done, but each and every minute may not come, but we have to do angiogram at least within next 24 hours of patient. So whenever we get to see a patient with ST elevation, first thing what we have to do is we have to make sure door in and door out time of PCI capable hospital where angiogram is available in the nearest hospital, such that angiogram and angioplasty to be done within 120 minutes. You can see this box in the middle. Transfer from primary PCI center where first medical contact to device time as soon as possible. That is within 120 minutes. Within 120 minutes, the totally occluded vessel should be opened from the time the patient reaches you to from the time vessel is opened. It should be less than 120 minutes. So these are the medications like tenecteplase, altiplase, alteplase, streptococcus. These are the injections which previously people used to use for opening that 100% blockages. But its efficacy is hardly 60% by streptococcus, 70% by altiplase, and 85% by tenecteplase. So angiogram and angioplasty are gold standard compared to these injections. So primary angioplasty is the preferred treatment after. So what are the complications developed after MI? Most common complications are arrhythmias. That is tachyarrhythmia like VT, SPT. Management of VT, that is ventricular tachycardia, is basic adoration, giving shock, and management of SPT is vagal maneuvers. You will be knowing vagal maneuvers, carotid massage, or giving beta blocker, or calcium channel blockers like glapomila. Then if patient develops a organ may be given. If patient develops bradyarrhythmias like complete heart block or heart rate of less than 50, less than 40, we can give atropine and increase the heart rate. And we can use pacemaker to increase heart rate. So shock is another complication of MI where we have to manage with antidotes like noradrenaline, dopamine, adrenaline injections, and mechanical circulatory support devices like IABP, Impella, Private are present. When no injection works, we may have to use these machines which can take over function of heart till heart recovers. Thank you.
Onset of chest pain and proposing possibility after 12 hours proposing possibility.
Actually, cardiac enzyme, troponin is a cardiac enzyme present in cells of the myocardium of the heart. When there is myocardial infarction is death of myocardial cells. When cell death occurs, first thing is breakage of the cell membrane and leakage of contents of the cell. So enzymes present in the cell are leaked outside the cell. So as soon as patient develops MI, enzyme will be present in the body or blood. So to detect that level of troponin, it will take at least 1 to 2 hours usually. Previously, they used to do troponin, which is measured in milligrams. It used to take 3 to 4 hours or sometimes 6 hours. Now we are doing high sensitivity troponin, which is measured in nanograms, like 4 nanograms is also measured. So now we can get troponin positive even after 1 hour of MI. And troponin released from dead myocardial released into the blood will stay for next at least up to 7 days or 10 days. So if you do repeat troponin after 3 days, it will still be positive. If you do repeat troponin after 5 days, it can still be positive. But usually the pattern will be the release will be immediate, and the peak of the troponin levels will be by around 12 to 24 hours or maximum 48 hours. After that, it will start dropping over the next 7 days or 10 days. So cardiac biomarkers are detected in blood after 1 to 2 hours and peak by 1 to 2 days, drop by 7 to 10 days or maximum 40 days. After 40 days, it will usually be negative.
ಮಾಡರ್ನ್ ಮೆಡಿಸಿನ್ ಜೊತೆ ಆಯುರ್ವೇದಿಕ್ ಸಂಬಂಧಿತ ಕಾಯಿಲೆ
This lecture is to motivate you to invent something from Ayurveda. Because I am not Ayurveda, it is difficult to comment.
So, case scenario, 30-year male operated for ear sustained distal radius fracture. Pre-op ECG, X-ray, everything is normal. Operated with plating under brachial plexus block. Post-op day 35, suddenly collapsed. Post-mortem report came as death due to cardiac arrest. Infarct was the reason, myocardial. So role, post-op he was on analgesics and calcium.
It is the most abused term in our society, cardiac arrest. Asamdalli Ayurveda cardiac arrest. So cardiac arrest is a terminology used as a final. Heart temporary. So Sattaga, 3 important organs of the body: lung, heart, brain. These 3 are important organs. The last functioning organs. So lung, if stops functioning, the person will die. Heart, if stops functioning, person will die. If brain stops functioning, person may not die because heart and lungs will make the person alive still. So these 3 are the underlying causes. So if patient develops pneumonia and died, heart stops, the doctors over there, without underlying evaluation, they just say heart has stopped, cardiac arrest. There can be underlying any other cause, but they will just write cardiac arrest. Cardiac arrest is a terminology used for final arrest of the heart. It does not indicate anything. And once the patient dies, heart is also dead. So his myocardial is also dead. So if you do postmortem and if you do see myocardial they are dead. So it is difficult to say it is only cardiac arrest and nothing else.
Is there any role in analgesics inducing MI?
No role of analgesics in inducing acute MI. Analgesics will usually, like what the most common manifestations seen in analgesic abuse is renal dysfunction. So they will receive diclo injections for all small things over the last 10 years or last 5 years. They will end up in chronic kidney disease. So abusing of analgesics will cause kidney disease, kidney dysfunction, but not heart attack immediately.
Unexplained. Death is unexplained in that patient.
Death is unexplained, but I feel evaluation is maybe incomplete. In India, autopsy is done by forensic experts, not pathologists. So we cannot say the autopsy is perfect. ಇದು ಸರಿ ಎವಾಲ್ಯೂಯೇಟ್ ಮಾಡಬಹುದಾಗಿತ್ತು ನಾವು.
Kind of disturbance, like the kind of chest cancer, whatever previous prevalence in our like giving the diclofenac injections, it may lead to a kind of death. Means for giving the diclofenac injection, the patient has died. There is a related to that giving the diclofenac injection.
Yeah, we have seen few instances in Kudligi also. ಒಂದು ಇಂಜೆಕ್ಷನ್ ಕೊಟ್ಟರು 10 ನಿಮಿಷ ಪೇಷಂಟ್ ಕಲೆಕ್ಟ್ ಮಾಡ್ಬಿಟ್ಟ. ದಿಸ್ ಇಸ್ ಯೂಶುವಲಿ ಅನಾಫಿಲಾಕ್ಸಿಸ್. Allergic reaction developed to that injection. Diclofenac is just an analgesic. It can be given to anyone. If patient has died because of diclofenac injection, most likely it will be because of anaphylaxis. Allergic reaction developed to that injection. We should have revived the patient by giving adrenaline injection immediately by resuscitation, by giving chest compressions or intubations or IV fluids. So anaphylaxis management is foremost when we encounter that situations like adrenaline injection, IM or IV, and sudden rush of fluids and CPR. Students, nothing else?
Arterial fibrillation and what is the significance?
It is atrial fibrillation and atrial flutter. Significance of that is when there is underlying pathology in atrium, the patient can develop atrial fibrillation or atrial flutter when the atria is significantly enlarged. Significance means it will complicate it into ventricular tachycardia and LV dysfunction, heart failure. So atrial flutter fibrillation ಬಂದಾಗ fibrillation means rate of around 300. Flutter more than 250. ಅಷ್ಟು ರೇಟಲ್ಲಿ ಹಾರ್ಟ್ ಬಡ್ಕೊಂಡ್ರೆ ಹಾರ್ಟ್ ವಿಲ್ ಫೇಲ್ ಅಂಡ್ ಪೇಷಂಟ್ ವಿಲ್ ಡೆವಲಪ್ ಹಾರ್ಟ್ ಫೇಲ್ಯೂರ್ ಸೈನ್ಸ್ ಲೈಕ್ ಡಿಸ್ನಿಯಾ, ಫ್ಲೂಯಿಡ್ ರಿಟೆನ್ಷನ್ ಅಂಡ್ ಎಲ್ವಿ ಡಿಸ್ಫಂಕ್ಷನ್. ಸೊ ಇಫ್ ವಿ ಡೋಂಟ್ ಟ್ರೀಟ್ ಇಟ್, ಇಟ್ ಕ್ಯಾನ್ ಪ್ರೋಗ್ರೆಸ್ ಟು VT ಅಂಡ್ ಡೆತ್. ಸ್ಟೂಡೆಂಟ್ಸ್
Diseases of the arteries. What is the reason for referred pain and other diseases?
What is the reason
For referred
pain?
referred
Referred pain.
and other diseases. Radiating pain.
Radiating pain. It is all dermatomal distribution. So distribution of nerve supply, you might have studied in anatomy. So dermatomal distribution. The same nerve plexus which supplies this back, T3, T4 or T5, supplies to aorta in visceral plexus. So both will go and give message in T3 level as pain. So your body will perceive pain as back pain, though the pain is from aorta. Actually, you should have answered this question because you are more perfect in anatomy.